Our next speaker will be our very own Dr. Rawa. He will be discussing pilonidal tissue under the microscope, a histopathological journey. Dr. Rawa, please take the stage.
Is it working? Okay. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Good morning, everyone. My name is Rawa Muhsin. I'm a pathologist here at Smart Health Tower. And inshallah, I'll be talking about the histopathology of pilonidal disease. So first of all, starting with the etymology of the word, pilonidal sinus means a nest of hair within a pocket. This pocket is most commonly seen in males and usually around age 20. We won't go over the clinical presentation as I think it's pretty clear to most of you, and it will probably be discussed in the other seminars. But in terms of pathogenesis, as Dr. Omar exhaustively discussed, initially, this disease has been described since the early 1800s. And for a while, up until the start of the 20th century, the congenital theory was favored, meaning that you had embryologic remnants within the skin of the natal cleft that then enlarged over time, and they collected hair, and this became inflamed, and this led to the disease. But there were some observations that went against this theory, mainly the presence of gender disparity. It doesn't have the same incidence in males and females. If it was a congenital abnormality of the skin, you wouldn't see that. The second thing is the late onset in adolescence. If it was a congenital condition, it would start earlier in life. And then, of course, there was the association with some occupations like the Jeep drivers that Dr. Omar mentioned. Also, you can see it in some occupations that are related to hair, like in hairdressers or barbers. They can develop it between their fingers. And this also argues against the congenital theory. If it was specific to the natal cleft, if it wasn't, then you wouldn't develop it in other sites of the body. And of course, with regards to the histologic findings, usually in embryologic remnants, you see the lining of a cyst, you see other adnexal structures within it, but we do not see that within pilonidal disease. And all of these argue against it being a congenital condition. So that's why over time, the acquired theory became more favored. Bascom, as Dr. Omar mentioned, argued that the initial pathogenic event was actually the enlargement and of a hair follicle. This hair follicle would start to accumulate keratin debris, and then also secondary hair that is shed from the head. This hair will accumulate within it. It will incite an inflammatory reaction, and then you can develop secondary infection, abscess in the tracts. And Bascom actually, what he did was that he took this is not his paper, by the way. He took the midline pits that you can see in asymptomatic or early disease, and he examined them, and he showed that they were actually abnormal hair follicles. And that's why he argued that the hair insertion was not the main pathogenic event. It was just the enlargement and the dilatation of the hair follicle, and that the hair insertion was a secondary event later in the disease. And in support of this theory, actually, we have a number of other conditions that are similar to pilonidal disease. And even histologically, there is significant overlap between them. These include the main differences that they occur primarily in other sites of the body. The first one is acne inversa, which is also known as hidradenitis suppurativa. This most commonly presents in the intertriginous areas. Acne conglobata, which is a form of regular or common acne, this develops on the face and chest. And then we have dissecting cellulitis of the scalp. These three, along with pilonidal disease, form this so-called follicular occlusion tetrad, which is due to a disorder or abnormality of keratinization of the hair follicles. And that is why this paper that I put here argues for the possibility of using retinoids in the treatment of pilonidal disease, just like it is used in acne, because they may have some shared pathophysiology. But then Karidakis argued that no, it's not actually the abnormality of the hair follicle that leads to the disease. But the only important event in the pathogenesis is the insertion. And he went on to he has done thousands of cases, and based on his own research, he firmly believes in this theory. Why? He developed this equation of three major involved in the pathogenesis of the disease. These are related to the hair itself And then we have factors related to the insertion process of the hair. And thirdly, the skin. So the more of these factors that you have, the higher your risk of developing pilonidal disease. So you can see that some of the factors that are related to the hair itself include the number of hair that is shed, meaning the more hair that you shed from your hair and from your back, the higher your risk. The acuteness of the root of the hair, because these are from his papers, two of his papers. I think this is from the 1991. You can see on the well, that's my right side, I guess. You can see that he argued that it's actually the root of the hair that is inserted, not the tip of the hair. And that's why he argued that shaving the area it actually doesn't make sense. It's not the hairs around the tract or the area that lead to the development of the disease. It's the loose hairs that are shed from above and they insert through their root. And you can see these spines on the root of the hair. They have this acute angle, so they can get inserted into the skin, but they cannot exit through that tract. The one that you can see on the right. So if you have some genetic differences in the characteristics of the hair, in the acuteness of these spines, in the roughness of the hair, all of these will lead to differences between individuals in their risk for the development of the disease. And then we have, of course, the factors that are related to the insertion process. This is where most of the etiologic factors that we hear about, like obesity, like prolonged sitting, like trauma to the area, come into play, because these will affect the ease with which the hair fragments will get into the skin. So if you have a deeper cleft, if you are more obese, if you have prolonged sitting, all of these will induce trauma to the area and will make it easier for the hair fragments to get inserted. And then finally, you have factors that are related to the skin itself. If you have acquired factors, like if you have a wound on the area, if you have macerations, if you have soft skin, and then of course, genetic characteristics of the skin itself, all of these will affect your likelihood of developing the disease. He actually had an equation, but it becomes a bit mathematical, and we don't need that here. So he argued that the hair will start. This is the primary tract. The first hair will enter here. Other hairs will follow. They cannot exit through the primary tract. You get secondary infection here. You get inflammation. You develop an abscess, and then you can develop secondary tracts. And through these secondary tracts, the hair can be extruded when it becomes a chronic pilonidal disease. So in summary, I guess that there are elements of both of these in many cases, as we will see in the histology. It may be that in some cases, it starts with an abnormal hair follicle, and then the shed hair from the head will enter into this abnormal hair follicle, and this develops into the abscess. Or it may be that it's just abnormal skin at the area. It's not a hair follicle that can be injured by the hair fragments themselves. They can enter into it, and they can create the abscess with the secondary tracts. So these are some examples of our cases. I didn't get let's say, a particularly nice case within this period that I was preparing the presentation, but I'll try to explain it on this. You can see that this one on top, this is the surface. You can see there is a midline pit on the surface, and we can demonstrate that with a probe that we can enter into the skin. This is not an iatrogenic probe. We did not induce this. The pit, we just insert the probe into it. And you can see on this is the roof of the cavity. So the bottom of the cavity would be here, but we receive the specimen like this. And you can see this is the end of the probe that is exiting the bottom. Now, if we slice the specimen along this probe, you can see that this is the tract through which we took the probe. And this is one of the tracts of the abscess cavity. So this is the roof of the cavity. This is the tract, and the bottom, or let's say the floor of the cavity would be in separate fragments. This is another case that we received yesterday, and you can see that it's still pretty fresh. So this is the surface of the skin here. You can see that we can enter the probe. It doesn't exit because we have the base or the floor of the cavity in this case. But if we slice it open, you can see that this is the tract itself that we entered the probe through, and this tract extends, and we have a cavity here. This cavity corresponds to that. So this would be the cavity, and this would be one of the tracts leading onto the skin surface from the cavity itself. Now, if we take microscopic sections of these are slides, but I'm taking pictures of the slide itself, not under the microscope. All of these are oriented with the skin on top and with the cavity on, or the subcutaneous fat on the bottom. And you can see that all of them have defects in the skin surface, all four of these. And this would be the side of the tract. So histologically, what do we see? This is one example in which we have the remnant of a hair follicle. You can see the skin on top. This slide, which has a slightly bluish tinge on the surface. This is the skin, and you can see that it's extending downwards. Now, just imagine for a moment that this is actually extending down further. It's just due to the oblique section that we had in the, because as you can see, this is a continuation of that. This is the same slide. It's starting at the surface, it's coming down, and then you can see it's the continuation of the cavity. It's still lined by skin or epidermis. You can we are going down further, and it's still lined by skin. And then when you get to the bottom of the cavity, you don't have skin anymore. So this was a hair follicle that got dilated, and then it accumulated the hair fragments, the debris, and developed into the abscess. In other cases, we don't see that epidermal lining. In fact, in most of the cases, we don't see the skin lining this cavity. And this kind of supports the theory that it's not a congenital condition, or that it's mostly not related to abnormal hair follicles. So in most cases, we can just see a tract, or let's say a cleft, which is surrounded by the inflammation. This is another case in which we only had a cleft. We didn't have the epidermal lining. So what do we see within the cavity? You can see hair. You can see these lovely refractile yellow fragments. These are fragments of hair shaft, and they're usually surrounded by these multinucleated giant cells. You can see that this is a giant cell here. It has multiple nuclei. This is another giant cell. These giant cells are trying to eat up the hair fragments and get rid of them, but they are miserably failing to do so. This is another example of hair fragments, and you can see this lovely large multinucleated giant cell which is trying to eat it up. You can see another giant cell here trying to eat it up, but they're failing to do so. Of course, they can't, because this is too much for them. So in addition to the giant cells, we have a lot of inflammation. Usually have chronic inflammatory cells. These are plasma cells, lymphocytes, and also acute inflammatory cells like neutrophils. Especially when you develop an abscess, you'll have a lot of neutrophils within it. And that's when the patient will have signs of an acute disease. They'll have erythema, they'll have pain, and it will be, of course, tender. So what's the role of pathology? Should we even examine these specimens? First of all, as Dr. Hemon mentioned, we have a lot of differential diagnoses, and pathology can help to distinguish among these. Most of these actually differ clinically. So a perianal abscess will not have the draining tract unless it's a secondary development. An anorectal fistula is usually not located at the top of the nasal cleft. It's located closer to the anal canal, or the anal opening. And we'll get to Crohn's disease in a minute. The second major importance of pathology is in the exclusion of the development of a secondary malignancy, as we'll get to in a bit. So in a perianal abscess, histologically, we don't see a tract, we don't see an opening. This is the skin. So in this case, I've put the slide like this. This is the skin surface, and this is the deep part. We have the subcutaneous fat over there. The skin is fine. It's just mildly thickened. We have some inflammation in the dermis, but then the bulk of the inflammation is located within the subcutaneous fat. We don't see hair within it, like we see in pilonidal disease. The second thing is an anorectal fistula. Now, in anorectal fistula, we do see a tract. We do see an ulcerated opening on the epidermis, but you don't see hair within it. Second thing is that usually you can see some anal glandular mucosa, which is the deeper end of the fistula tract that it connects to. And we can actually see this in many of the cases. And finally, with regards to Crohn's disease, again, it doesn't present as a pilonidal sinus. It presents as a fistula. And the fistula, we said, clinically is different. It's closer to the anal opening, and we can see granulomas within them. These are two different cases that we had. All of these pictures are from our cases, by the way. So this one was an incidental finding. It was a fistula tract, the one on the right. And all of these pink round nodules, all of these are granulomas that you can see within them. So the patient after that had to be worked up for Crohn's disease to see if he had. And this one actually was from an anal or anorectal fistula. The patient also had ileal and colonic biopsies. All of them showed granulomas in the ileum, in the colon, and in the anorectal fistula. So this was pretty typical for, or a textbook example of Crohn's disease. So histologically, we can help to distinguish between Crohn's disease and a regular fistula, or if you are in doubt clinically with a pilonidal abscess. Now, secondary malignancy can develop in pilonidal disease just like it develops in other chronic ulcers, burns, and it's basically the same mechanism. This chronic inflammation will affect the DNA repair mechanisms through the generation of oxygen-free radicals. So it's similar to a Margolin ulcer. Now, this is mainly seen in chronic cases. So you don't see malignancy developing in a 20-year-old male patient who has an acute pilonidal disease. It's almost unheard of. And in support of this, there were over 80,000 cases of pilonidal disease in World War II I couldn't find the original paper, but it was cited in a number of other papers. Probably it's old, it's not indexed in the online repositories, but none of them had carcinoma. Imagine in over 80,000 cases. Why? Because these were soldiers, they were young. So, and the disease was acute. It wasn't long-standing, they were not old, so none of them had carcinoma. And that's why it's argued that it's related to the duration of the disease and the age of the patient. But of course, the fact remains that this is underreported. So somebody may develop a squamous cell carcinoma in the natal cleft. They'll just excise it as a squamous cell carcinoma. Nobody will report it, and nobody will hear about it. So the incidence may be slightly higher, but we don't know for sure. This is one of the landmark papers. It's a comprehensive review of the topic. The highlights of the paper are that you have 140 cases of pilonidal carcinoma in the literature from 1900 till 2022. Now, these are reported. So if we add the case of Dr. Omar that we had, it would be 141, but you haven't reported it yet. You can see that the mean age for pilonidal disease itself was 20 years. The mean age for pilonidal carcinoma is around 50. So they're older patients. Again, the majority are males. Of course, the majority are squamous cell carcinoma. And if you compare it to primary squamous cell carcinoma that is not related to pilonidal disease, you can see that it's worse in every possible aspect, in the 3-year, 5-year, 10-year survival rates, in the recurrence rate, and in the rate of metastases. You can see the 5-year survival in primary squamous cell carcinoma is around 93%, while in secondary or in pilonidal carcinoma, it's around 60%. You can see the recurrence is almost 10 times that of the primary squamous cell carcinoma, and the mets are about twice. So it has a worse outcome, and it's similar to the outcome of marginal ulcer or squamous cell carcinoma developing within a burn or a chronic ulcer. So should we examine the specimens of pilonidal disease, or should it be thrown in the trash bin similar to some other specimens like tonsils? Well, the fact remains that aside from the medical legal aspect of examining every surgical specimen, that you want to confirm the diagnosis. Almost always we see the hair fragments within them, we see the tract. You want to exclude some differentials like Crohn's disease, and you want to exclude the development of a secondary malignancy. Thank you very much.
Okay, thank you, Dr. Rawa, that was a very deep dive into histopathology aspect of the pilonidal diseases. If anybody has any questions for Dr. Rawa, I think it was overload of information. Dr. Barham will take the first question.
We will start from the last slide.
Okay.
Which patient you need to see or to be referred for the biopsy?
Exactly. That's a very good question. By default, most of the samples should be sent for confirmation exclusion. But if you are asking to select a specific segment of the population with this disease, the older patients, those who have recurrent or long-term disease, and if you are clinically suspicious, if the ulcer looks ugly, if it has rolled up edges.
Every patient. This is the message.
You could argue. The papers that I showed, some of them actually argue that because they reviewed their own cases, some of them had like 700 cases, and they looked at them, none of them had malignancy. Another paper reviewed like 1,000 cases, none of them had malignancy. So they argued, well, we don't need to examine them anyways. But other cases, like you can argue with for example, with a gallbladder, with an appendix. In the majority of the cases, you know what the report will come back as. But you can have surprises.
As you know, 1% in all in the gallbladder, in the appendix, risk of the tumor.
Exactly. Yeah, exactly. The risk here is lower.
Extremely rare.
It's about 0.1%.
Yes.
Yeah.
The second question: how many percentage of the Crohn's disease?
Okay.
In the PNS, you will diagnose it by pathology.
No, we don't see Crohn's disease within PNS.
No, I mean the histological pictures of the Crohn's.
Okay.
Non-caseating granuloma in the.
Yeah, it's uncommon, of course. It's uncommon.
I think
to begin with, diagnosing Crohn's disease with an anal fistula is a rare, and then you cannot have the granulomas in all the cases. Yeah. So yeah, it is uncommon.
So still you need with the pathology clinical suspicion.
Of course.
The surgeon should tell you, please.
But even if one of the cases that I showed was removed as a simple fistula, actually, and clinically it was not suspicious, but you can see logically it came back chock full of granulomas. So yeah, you cannot really expect it based on the clinical findings alone all the time.
Thank you so much.
دەست خۆشتۆڕەوە بۆ پریزنتیشنە جوانە بەس لەسەر قسەکەی کاکتۆر بەرهەم احتیمالە کرۆنس وەکو perennial condition دەرکەوێت لە PNS. بەس بیرمان نەچێ یەکێکیکە لە پریزنتیشنەکانی کرۆنس ئیکسترا ئینتەستانەڵ پریزنتیشنە. مەسەن وەکو کاکتۆیە من وتی پادەرمە gangrenosom.
Yes.
How it's formed on the leg could be formed on the sacrum.
Exactly.
Not the يعني نخوش كرونس شيء هبيو لقالي شيء كرونس سكيني شيء هبيو وكو بيانيز در كده histologically شد النية
that's a good point.
Extension بالضبط.
I see your
I
point.
think it's around 60%. Yeah, it's still so 40% will
Yes.
remain to do
Exactly.
more work by colonoscope, by MRI of the or MRE of the
Exactly.
ileum.
Exactly.
This is what I mean.
Yes.
Agar biopsy with Crohn's, this
Of
does
course.
not exclude
Well,
Crohn's.
even in biopsies
Or
of
could be a skin presentation of the Crohn's,
Yes,
like
exactly.
on the leg, for
Yes,
example.
exactly.
even in biopsies of the ileum itself, if it's involved by Crohn, we may not see granuloma sometimes in a smaller percentage of the cases. So it's a gradation, and you can suggest it, you can strongly suggest it, you
Yes.
can almost swear that it's the condition based on the findings that you have.
Yes.
Doctor, I have a question about this basal cell carcinoma arising from the chronic PNS as a marginal ulcer, as a natural history. It is not surprising to be arising from the chronic ulcer causing, for example, the basal cell carcinoma.
Yeah, it is. It is actually, but remember that it's a primary carcinoma of the skin. It's arising from the basal layer of the epidermis. It's the same structure. It's just the simple fact that squamous cell carcinoma happens to be more common. Otherwise, it is the same structure. It's the same epidermis, just the basal layer. That's what it's arising from. So it is not surprising, actually. But it is surprising why 95% of the cases are squamous. I don't have an explanation for that. But it is expected to find other types of primary skin carcinoma developing within a pilonidal disease because it's the same structure.
Thank you.
Okay. If Dr. Peter has any questions, I think you raised a hand for a second there, Dr. Peter.
Okay.
That's fine.
Right. Thank you.
Okay. Thank you, Dr. Rawa.